Some places, there are some places where there are forms and other things. You will get copies of these slides, and there will be links to those forms if you are deciding that you would like to use those in your program. There will also be times that you can ask questions, so please feel free to ask questions along the way. We'll also be talking a little bit about how permanent supportive housing might be a little different than rapid rehousing as we go through the slides. And then Mindy will talk to us about harm reduction. I know that was a discussion that we had early on in some of our discussions about the community standards. And Mindy will be able to answer any questions and provide some good information on harm reduction. So, Mindy, do you want to introduce yourself? Do we have Mindy?
Hey, everybody. Hi, I'm Mindy from Homebase. I have been at Homebase for a few years now, but I'm actually, some of your faces look familiar because I was at the National Alliance to End Homelessness for a long time, working on policy there. And I started my journey a long, long time ago at a very high barrier shelter for families experiencing homelessness in Mobile, Alabama. So I do have a lot of thoughts about working through barriers and really navigating the tension of housing first and harm reduction. And Mary offered you too much for what I might give you. What I hope to do is just maybe offer some ideas and facilitate some discussion with you guys about harm reduction in practice and really kind of navigating the tension and the reality of that. But mostly, I think you guys do have the answers, and it's a matter of just kind of coming together and problem solving and talking things through. So that'll be towards the end of the presentation. I am working from a Starbucks this morning in Baltimore, Maryland, where I live. So I am going to, after this little blurb, turn my camera off so I can not hear any lag as Mary is doing her presentation. Thanks, you guys.
Thank you. Thank you, Mindy. Okay. Nicole, can we go to the next slide, please? So permanent supportive housing, we're going to talk today about eligibility and record keeping, the coordinated entry and referrals to permanent supportive housing. I know you all have spent a lot of time on coordinated entry and prioritization. We'll talk a little bit about how that works with the referrals to permanent supportive housing. We'll talk a little bit about housing first, and Mindy will lead that discussion on harm reduction. The eligibility requirements for permanent supportive housing include housing eligibility requirements. You can't just pay for housing anywhere, and the people that you serve. The unit must be under HUD's published fair market rent. It needs to meet HUD's housing quality standards, and that will change in October to something called Inspire. Inspire aims to pull together HQS, lead-based paint, and some environmental requirements, so it's all one process that will be required for COC and ESG programs in October. So there will be more information on that coming. As we get it, we'll forward that to your community. We need to make sure the unit is accessible for the people who will be in those units. As you know, people are eligible for permanent supportive housing if they have a documented disability. That may be a physical disability. It may be a mental health or emotional disability or some other disability. But if someone is a wheelchair user, the unit must be accessible for that person. If the person has hearing or sight issues, it needs to be accessible for that person. And if it's leasing, as you know, permanent supportive housing could be tenant-based rental assistance. It could also be leasing. If it's leasing, an environmental review has to be on file. For people to be eligible, the household needs to be prioritized through your coordinated entry process. The household's homelessness has to be verified. Generally, we're looking for third-party verification, and we'll talk more about that. An adult household member has to have a documented disability. We'll also talk a little bit more about that. The disability has to be documented by a professional who is eligible to make a diagnosis in your state. They don't have to tell you what the disability is. They just have to say that there is a disability that is expected to be of long duration or permanent disability, that it impairs activities of daily living, and that permanent housing would provide, would help that person live more stably. The household's resident rent must be affordable. So therefore, you can't charge someone 80% of the rent. It's not arbitrary. The resident will pay 30% of their adjusted gross income for the permanent supportive housing option. The people you serve must be unsheltered or residing in a shelter at the time of identification. They don't have to stay there while awaiting housing. They could be identified by you as being unsheltered, and then maybe they'll be in a hotel through some of your other shelter resources, or maybe they'll temporarily stay with someone. That doesn't change the fact that they were identified on the day that they were experiencing homelessness, and that you will have third-party documentation for the time homeless prior to identification. The person must have a documented disability. The project may be dedicated plus. That is a continuum of care term that is specific to permanent supportive housing. And that means the person doesn't necessarily have to meet the full definition of chronic homelessness, but they may be having some very difficult times in their homelessness because of their disability. They may be very, very, very ill and be prioritized by coordinated entry to be eligible for permanent supportive housing, even if they don't have a year of homelessness. They may have 6 months of homelessness, but be prioritized higher because of their disability status. Dedicated Plus allows for that. If the project is dedicated to serving chronically homeless persons, that means that everyone who is in that particular permanent supportive housing project must meet the definition of chronic homelessness. That means that they have either been homeless for 12 continuous months or 4 separate occasions in the last 3 years, but their homelessness during those occasions must total 12 months, and that needs to be documented by third-party sources for at least 9 of those months. And we'll get into the details of that, but it's very, very important that we know that 12 months of homelessness is required for the definition of chronic homelessness, whether it's 12 continuous months or 12 months over the last 3 years and 4 separate occasions. The 4 separate occasions means that there was a break of homelessness for at least 7 days, and those can be self-certified. You do not need third-party documentation for a break, but it will require you to do some sort of timeline showing when the person was experiencing homelessness, when the person was out of their homelessness in a break. And once you do that timeline, they then sign and certify that that is indeed accurate. So people should not remain homeless while they're waiting for their documentation. We talked about this a little bit when we went through the standards. The time homeless, meaning documenting that 12 months or documenting the 4 times homeless in the 3 years, you can get that third-party documentation during the first 180 days of housing in the PSH program. The disability documentation can be completed within 90 days. So let's imagine the person has an upcoming mental health appointment, and that's when you're intending to get the proper documentation. They don't have to continue to be homeless while they're awaiting that appointment, they could move into the PSH unit while you're awaiting that appointment. The person goes to the appointment, has the letter then from the provider that goes into the file. And as long as that happens within the first 90 days, you're in compliance with the PSH program rules. Until that proper documentation can be completed, self-certification and case manager observation will suffice for those first 90 or 180 days, depending on the circumstance. The documentation that counts as third-party documentation would include HMIS documentation. If someone has been going every 2 weeks to the Salvation Army for a shower and some other services, and the Salvation Army has recorded that in HMIS, that record will count as a third-party documentation for that time homeless. You also can have written documentation from the outreach worker, the person who saw the person experiencing homelessness, the person who was doing the outreach and met the person at their tent or at their place that they're experiencing homelessness. That written observation is indeed third-party documentation. If someone has been kind of disconnected even from outreach, it could even be a community member. Let's say they have stayed, spent the night in the back of a convenience store most nights for several months, and that convenience store operator could actually write a letter stating so. That is also third-party documentation. It does not have to be someone in our sector. Also, third-party documentation would include a letter from an institution like a jail or the mental health hospital or any other type of institution. Please remember that someone counts as experiencing homelessness if they're coming from an institution of care, if they were homeless when they arrived, and they spent less than 90 days in that institution. So at that point, the institution can document that they were indeed homeless when they came in and that they were there less than 90 days. In that particular case, when it's a healthcare worker, when it's institutional care, when it's someone going to an appointment like that, then the person does not have to actually visually see that person experiencing their homelessness in their place where they're sleeping, but they can document that the person is homeless based on that person's assessment of in their process. So if they're going to the hospital and they say they were homeless, as long as that's in the hospital's notes, that will count as third-party documentation. Third-party documentation is preferred for all documenting of all time someone has experienced homelessness. It's required for at least 9 months of the 12 months if someone is chronically homeless. And third-party documentation is required for at least 75% of the people in your program. And all breaks in homelessness can be self-certified. Now, when we compare this to rapid rehousing, keep in mind that people do not have to have a specific time homeless for rapid rehousing, though your coordinated entry may prioritize people with the longest times homeless. And they don't have to have a documented disability in rapid rehousing. However, they must have a documented disability for permanent supportive housing. The reason is that permanent supportive housing is expected to serve the people with the highest needs, meaning that there are more services available and there is no time limit to that service. Rapid rehousing has a time limit of 2 years, and the case management strategies are different. The case management strategies are designed to move someone forward to be self-sufficient at the end of that 2 years. So keep in mind that permanent supportive housing is a higher level of care, and permanent supportive housing does not have a time limit So therefore, it's designed to serve people with the highest needs. This form that you're looking at is available at the link that's on the slide that when you receive it, you'll be able to see it. But the reason it's on here is to indicate that your documentation of time homeless cannot be from a case manager that says, so-and-so has been homeless for 1 year and I have been talking to them off and on for a year. No, you have to have each and every month documented. Now, the person does not have to say that they know for a fact that each month that they were homeless for the entire month, but they have to certify that they did indeed see that person, or you actually see an HMIS for each month, that that person was indeed experiencing literal homelessness for at least a day of each of the months that you're certifying. So this form that you're looking at breaks up each and every month so that you can state that yes, that person was homeless on that month 1, month 2, month 3, maybe not month 4. Maybe you're actually using a total of 3 forms to indicate the 4 times in 3 years, but each month has to be certified. And keep in mind, because this is something that will be looked at in any kind of monitoring, because the rule is clear that each month has to be certified. 9 months for 75% of your population in your programs, 9 months have to be third-party documented for 25% of the people in your program. Breaks in homelessness, as we said before, can be self-certified. And the definition of the disability, as we talked about, is expected to be of long continuing duration. It substantially impedes the individual's ability to live independently. It could be improved by the provision of more suitable housing and is a physical, mental, or emotional impairment. And keep in mind that this includes impairments caused by alcohol or drug abuse, PTSD, brain injury, or other things. So that is very, very important in the work we do, especially with the rise in addiction that we are seeing. Also, if someone has a developmental disability or HIV or AIDS, they are all automatically considered to have a disability and eligible for PSH. You will indicate the type of disability on file. You don't have to say specifically what the mental illness is. You don't have to say it's bipolar disorder or whatever the mental illness is. You just have to know that it's a serious mental illness. Other types of things. So you're talking about broad categories. You are providing case management that helps with housing stability. You're not providing the treatment for these disorders. You will be connecting to the proper professional for the treatment of the disability. Acceptable documentation needs to be attached to the form or in the file if you choose not to use that particular form. So you'll want to have on file the intake staff recorded observation of disability. That would be no later than 45 days from the application of the assistance, and then accompanied by supporting evidence, and that supporting evidence would be the diagnosing professional. Written verification of the disability from the licensed professional, or written verification from the Social Security Administration. If someone is receiving SSI or SSDI related to a disability, that would be sufficient, and the receipt of a disability check. But someone doesn't have to be getting a disability check to be eligible for your program, as long as they have the documentation from a licensed professional. So again, the documentation of housing requirements, fair market rents, rental and utility calculations, And inspections, the inspections currently are HQS. Later, they will be Inspire. For rapid rehousing, you're still going to be looking at fair market rents. You're going to be looking at the same rental and utility calculations, and the inspections will be essentially the same. The only differences are the types of services provided and the requirement for time homeless and disability for permanent supportive housing is not required in rapid rehousing. And I think Nicole has a quiz for us on some differences between PSH and rapid rehousing. Do you want to take over, Nicole?
Hi again, everyone. There is a quiz that should have popped up for you. It is anonymous. So if you go ahead and just read through the questions, you should be able to answer most of these based off of the information that Mary just provided. And then you'll be able to see the results as other folks participate. And again, it's anonymous, so your name won't show. Don't worry about getting anything wrong. And the quiz should be launched now, Mary.
Okay. So, okay, I see people are participating. Yay.
Right, we will end the poll or the quiz in like 10 seconds, and then we'll continue with the presentation.
Thank you very much for participating. So the PSH and Rapid Rehousing Program do have many of the same features and requirements. They do both require rent reasonable determination. They do both have to have inspections. So Rapid Rehousing does have to have inspections. The time limited assistance, you're right, is the difference. The permanent supportive housing does not have a time limit. It should be based on the person's needs up to a lifetime, as long as funding is available. A contract for the rental assistance, that's, you may have a contract for the rental assistance for both rapid rehousing and permanent supportive housing. For both of them, people would pay up to 30% of their adjusted gross income. And assistance in both programs can pay for application fees, security, and other deposits that move in. So thank you very much for participating. We appreciate your participation. Okay. So the amount of the residence rent will be based on the number of people in the household, the age of the people in the household, are they adults or are they children, the anticipated income, anticipated expenses, anticipated allowances, because there are allowances when determining the residence rent, and anticipated household paid utilities. There is a utility allowance allowed for these programs. The rent calculation, we'll just briefly go over this, but you will be doing this in your programs, and you probably already do. But you'll determine the annual income for all family members over the age of 18. That means if there's a college age student in the household and that college age student is working part-time, that income also is calculated. But you do get to determine the dependent deduction, which is $480 per dependent. There is also a child care deduction, the unreimbursed child care costs for dependents under 13. This could also be a disabled adult deduction. A disability assistance deduction would be the cost for necessary equipment or care. Medical expenses that are unreimbursed can also be subtracted, and these will be estimates based on prior years or based on the expectation of the upcoming year. There is also an elderly or disabled deduction, $400 for each family member over the age of 62 or who is disabled. When you take all that into account, that is the adjusted annual income. So it's the total minus all of these deductions. And then to determine the resident rent, you'll multiply the adjusted amount by 30%. So it is not 30% of the gross, it is 30% of that adjusted income. The other option would be to do 10% of the gross. So keep that in mind. When we look at utilities, if utilities are not included in the rent, they might be. If they are, then you don't need to worry about a utility allowance. But if they're not included in the rent and the resident is responsible for those utilities, then the cost of the utilities is considered in a utility allowance. You'll get that utility allowance from your local public housing authority. It'll be their schedule of utility allowances. You'll subtract that utility allowance from the rent, the resident rent that you already calculated. If it's a negative number, then that amount of money is actually paid to the household or can be used to pay a portion of the utilities on the household's behalf, as long as you have a written agreement with the household that that is how you'll be handling the utilities. And that's covered in this slide here about how to handle rent and utilities if the person has no income. They would receive that utility allowance reimbursement. The rules are linked on this slide. So when you get the slides, you'll be able to read those specific rules. But just keep in mind that if the person has zero income, then you'll likely be paying all of the rent and the utilities up to the utility allowance. If you're not paying directly to the person, because many of our programs don't allow for paying directly to the person by policy, if that is the case, then you will have an agreement with the person that you'll be paying their utilities up to the utility allowance amount. So the way to think about the utility reimbursement for participants in transitional housing or PSH programs, the utility reimbursement may be paid using operating funds. For program participants receiving rental assistance, the utility reimbursement may be paid using rental assistance funds. So it depends on how your budget line items are set up in PSH if you have leasing or if you have tenant-based rental assistance, that will determine where the utility allowance comes from. And so we went over the details of the residence rent when it's 30% of the adjusted gross income. We also went over briefly, but we'll say again, 10% of their gross income. And then if they're receiving payments for welfare assistance from a public agency, then there are different rules there. And so that will be designated specifically by the agency that they're receiving those payments. We need to be sure that we're not doubling up on rent payments. So if there is another agency paying rent on someone's behalf, we shouldn't be doubling up on that. We'll calculate residence rents at program entry and at the annual recertification date, and as needed when there's an income change. If someone's job changes or they got laid off, they need to know that they can come to you and let you know that they have less income and that their rent amount needs to be adjusted. And this is something that the case management team should be letting people know along the way, that they shouldn't wait 6 months and be behind on their portion of the rent. They should come to their case manager as soon as their income has changed so that the adjustment can be made. Inspections, again, the inspections right now are HQS, Housing Quality Standards. They will change to Inspire. But regardless of which tool we're using, all units that are paid for with COC rental assistance or leasing must pass basic standards. We want people to be living in safe, decent places, and the units must meet state and local codes. The recipient or subrecipient, meaning the people who are running the program, must physically inspect all the units. There was a waiver during the pandemic to allow for people to use pictures and have someone go and take pictures of the unit. Those waivers have all ended. People who are part of the program should inspect all of the units prior to expending any COC funds and need to do so at least once a month. Now, this is for the physical safety of the unit. It is not an inspection of the resident's housekeeping. It is specifically the physical unit itself. Does it have smoke detectors? Does it have a window in each bedroom? Does it have working appliances? Those sorts of things. Inspectors do not need to be certified. They do need to be trained. They need to know what they're looking for. They need to be able to address the deficiencies within 30 days. And oh, thank you, Mindy. Mindy put the information for Inspire in the chat. The owner of the unit has 30 days to address or correct any deficiencies. That would be both at entry and at the annual review. And you need to maintain the documentation of compliance with the inspection within your files. That is something that will be looked at in a monitoring. Lead-based paint is a really important piece of the inspection. There are online trainings for the visual inspection of lead-based paint. It is required for all units that were constructed prior to 1978, and it's specific to ensuring the health of young children. The environmental review is required for leased units, so I know that some of your PSH are leasing, some are tenant-based rental assistance. The environmental review is required for leased units. And there's other training on the environmental review if you feel like you'll need it. Oftentimes the city or the county can provide those environmental reviews for the program. So it will be based on the policies of your individual program. The cost of carrying out the environmental review is an eligible use of administrative funds, and they should be conducted by the responsible entity, which is the unit of local government. If your COC or someone else is doing those, they're not the responsible entity. Your HUD field office would then be the responsible entity. Accessibility, we talked about accessibility. The requirements are you need to be following the fair housing requirements, the Section 504 of the Rehabilitation Act and the Americans with Disabilities Act. You should not be discriminating against anybody, and you should be providing housing that meets the needs of people's choices and their accommodations if they do indeed have a disability, that a mobility disability or speech or hearing and sight. Record keeping requirements, all the fun stuff. The benefits, obviously you'll be prepared and it helps you make decisions, strengthens your reporting, and lets you know when you need grant amendments and other types of accommodations to your program. And you certainly need good records, not only to pass a monitoring, but also to apply and to apply for new funds and report to your funders. You'll be documenting your activities. You'll be maintaining files. In your HMIS, you should be putting notes in there so that you're continuing the record of providing services that meet the needs of the people that you're serving. You'll be obtaining documentation from qualified sources and the system to maintain relevant records. Some people use HMIS as an electronic file cabinet by uploading the records. Some people use a completely paper system. And if that's the case, make sure that you're following the rules as far as maintenance of records for the proper period of time, usually 5 to 7 years, and that you're keeping records in a locked file cabinet to maintain privacy and confidentiality. Confidentiality means that all records containing protected information are kept in a secure file, whether that's a digital file or an actual file cabinet. It needs to be secure. And the address or location of any housing or program participant should be kept confidential. It's not something that the whole world needs to know that this particular person is living in a subsidized unit. It's really for their safety. All records need to be kept at least 5 years, and eligibility documentation must be retained for 5 years after the final expenditure of all grant funds. So as we talked about, record keeping is really important. We have organizational record keeping, project level record keeping, and participant level record keeping. Organizational record keeping would be your standard operating procedures. Make sure you have standard operating procedures specific to your program. Typically, when your funder comes to do a monitoring, they're first going to look at your operating procedures to make sure they are within the rules and regulations, and then they will be looking at your program based on your operating procedures. So if your procedures and your policies are more restrictive than your funders, they will go by the more restrictive processes that are evident in your operating procedures. You'll need to make sure that you have a conflict of interest policy and that you have that policy on file, and that all relevant people within the organization have signed off on that conflict of interest policy. You must have participation of people with lived experience in your programs and at least one person on your governing board. That is a requirement set by HUD that is not new. It has been around forever and ever and ever. We're now moving toward the realization that one person certainly cannot represent everybody with lived experience in your community. So we're moving beyond just one person on the governing board to also advisory boards and others that are made up of a variety of people with lived experience who can advise your program so that it can be the best program it could possibly be. If there are faith-based activities, you need to make sure that you have a policy there, that there's no proselytizing, that people of all faiths are welcome in your program, even if it is a faith-based program. Affirmatively furthering fair housing is absolutely critical. You need to make sure that people are aware that your housing program is non-discriminatory and available to anyone who meets the eligibility requirements, and keep on file other federal requirements that pertain to your program. And so we just talked about establishing and maintaining your standard operating procedures and making sure that you're meeting the COC interim rule if your PSH is indeed funded by HUD. The policies and procedures should include program operations, financial management, grant-related information, staff and board information, and housing-related information, non-discrimination, and program participant-related information. The conflict of interest is pretty clear. You do know that you have to have a conflict of interest policy that's uploaded into your application for the HUD-funded PSH. And these points that are on this slide need to be covered in your policies. And we talked about the lived experience participation. At least one person who has current or former experience of homelessness has to be on your board of directors or equivalent policymaking entity. But we are also encouraging you, as we have through this whole process, to have an advisory board with people with a variety of experiences so that you have the perspectives that you need to have the best possible program. And then again, there's very specific rules for faith-based activities. You cannot discriminate against people based on their religious affiliation or lack of religious affiliation. Activities that involve overt religious content those activities must be outside of these programs and cannot be required. And any participation in religious activities must be voluntary. I think we can all agree that people oftentimes want faith-based activities, but they have to be voluntary. They have to be things that people have chosen. And then policies around affirmatively furthering fair housing. You'll keep records of the way that you have marketed your program. And we talked about environmental reviews. There's also other federal requirements that are absolutely critical in your program, so keep up with what those are. The audit piece is if you receive more than $750,000 of federal funds, not just the PSH funds, not just COC funds, but $750,000 in all your federal funds together. Could be CDBG, could be ESG, whatever it may be. It could be outside of HUD. It could be a workforce program or Department of Justice program, whatever those might be. If you receive more than $750,000 in federal funds, you must have what's called a single audit. And that single audit goes above and beyond a regular financial audit. It also tests your program pieces so that it's clear that a second set of eyes has looked at your program to ensure eligibility of your clients and compliance to HUD's rules. So then the project-specific policies and procedures, services provided, housing standards, your match, and any subrecipients and contractors should be part of your recipient and subrecipient record keeping. Check that. Okay. Next slide. So the program-specific policies will be what are your eligible costs? Who are your eligible clients? What are the restrictions around combining funds for specific activities? What are your reporting policies? Any restrictive covenants that are part of your program? Single occupancy agreements, leases and subleases. Any kind of agreement you have with your participants needs to be part of these policies. And then your coordinated entry written standards and providing COC assistance. These should be part of your policies. Even though your COC will have written standards for coordinated entry, you'll need to have your own program policies around how you are participating with that coordinated entry. You'll be naming the services that you provide. No one in PSH should feel like they are providing every service a person could possibly need. You will be partnering with other community-based service providers to provide those services as needed. So those partnerships are absolutely critical. And you'll be keeping records of the types of services that you provide and the types of services that you can make referrals to, and how you'll be keeping the evidence of those services. Housing standards, as we talked about, and as Mindy put in the chat, currently are housing quality standards to include the HQS, environmental reviews, and lead-based paint. Those will be combined together into the Inspire standard that will be required October of this year. Match is absolutely important. Match can be in kind, it can be cash, but it's 25% of your total program budget. So it's really important that you document the match funds that are coming in, but also your match expenditures so that it's clear that 25% of your program was supported by either in kind or cash match. And then subrecipients and contractors, there are very, very specific rules as far as who is a subrecipient, who is a contractor. We don't have time to go into all of those details today, but make sure you're working with your HUD field office and others to properly designate whether or not someone is a subrecipient or a contractor, because it will have real implications to how you're monitored and how your policies need to be written. And then for the participants, obviously, we already talked about the forms that you can use for the homeless status, eligibility verification to include documentation of disability, the participant income, their resident rent, and then all their other records. These can be digital or paper or a combination of both. Just make sure you're consistent along the way. And so the other slides will go into more detail. We're going to kind of push through these last slides so that Mindy has time to work through the discussion with you all, the really exciting harm reduction discussion. But make sure that all of these pieces of eligibility that we talked a lot about at the beginning of the presentation are indeed kept in the file of the participant. the income, how you figured out their income, what you use to determine their income, what you use to determine their deductions, need to all be in the file, both at entry and at that 1 year assessment mark. And then you'll want to make sure that there are records about the services that you're providing. The most convenient way to do this is through the HMIS notes, but also any other records that you may have as far as how people are receiving their services. As we know, services are voluntary. It doesn't mean that someone's just in housing and you're paying the rent. It means you're offering services, you're offering people options, you're offering them the kinds of services that might be helpful to them. You're also listening. We talked a lot about motivational interviewing. You're listening to what people have to say about the services they want and making sure that you are connecting them to those services and keeping that in their program, in their participant records. And then there'll be more slides that have more items that should be in those records, and you'll get a copy of these slides. You'll also be putting the information in HMIS. It is a requirement that that the information is kept in HMIS. You don't necessarily have to keep everything in a digital file cabinet, but you do have to include in a timely manner the creation of the record when someone enters, an annual assessment and update, and their project exit. These are measured by the COC, by HUD, by others to ensure that the project is functioning properly. And it also is helpful for you as you're running the program as a quick reference as to how people are doing individually, but also how the program is doing through your annual progress reports and other records that can be pulled through HMIS. And I mentioned the annual progress report. Everyone who has a HUD-funded permanent supportive housing program must complete an annual progress report in Sage. It says eSnaps here. It's not eSnaps anymore. It's Sage. And you have 90 days from the end of the operating year to complete that APR. So 90 days from when your grant ends. And that is 90 days. It's not 3 months. So it's not the 30th of that third month. Usually it's like the 27th or so because of, 30 days or 31 days. But it's 90 days from the end of your grant. You need to be putting in the APR. And now we'll take a break. And then we'll come back for the harm reduction.
Thanks, Mary. We'll come back at just about 35 minutes after the hour.
Thank you, Nicole. And discussion. Thank you, Mindy.
Thanks, you guys. And I appreciate my home-based colleagues being flexible. And I think when we talk about implementing housing first and harm reduction, especially in permanent supportive housing for folks with really complex needs, flexibility is kind of the word we should live by. So we're hopefully demonstrating flexibility right now. I had some harm reduction slides that I usually use, but actually Mary and I just got back from a training and I had added in a slide about harm reduction that I wanted to share with you guys. So rather than trying to just like flip back and forth for one slide, Mary and Nicole are gracious enough to let me kind of share my screen and use some different slides than I had originally used. But like Mary said, you guys will get access to these slides and including pictures of my cats, which I always use in all of my presentations, but that is not especially relevant. It's just in these slides. Like Mary said, I know you guys have done a lot of training already on housing first, but I think when we talk about harm reduction, It's really important to keep in mind that this is an important piece of the puzzle for doing housing first and doing it well. So I'll just breeze through the housing first slides. Again, you guys will get these just to revisit. Housing first itself is about framing homelessness as a housing problem. Housed people literally are not homeless, right? So we want to focus on ending the homelessness first, but it's not housing only, as you guys know. So we're getting folks into housing, but also getting them connected to whatever resources they say they need to maintain that housing. And then again, whatever it is that we think or they think or all of us think led to someone's being homeless in the first place, whatever those things are, they're best addressed from that stable foundation of housing. And most importantly, it's about understanding that people experiencing homelessness, again, whatever their complex needs are, whatever their barriers to stability, they are ready for housing by virtue of not having any. And again, the folks that you guys are serving are the folks that benefit the most from housing first and from approaching homelessness this way. And those are also the same folks who benefit from harm reduction. So again, I'm breezing through this just to make sure everything that we're going to talk about with harm reduction is absolutely rooted in the philosophy of housing first. So this one about housing first, I do want to spend a little bit of time on because it's not something that we usually talk about with housing first. For those of you who did know me when I was at the National Alliance, I did a lot of work on youth homelessness, and that was part of our field that wasn't maybe as far along on housing first as other parts of our field. So I learned a lot from providers who were purposefully doing housing first in the youth context. About really thinking about yes, it's an approach to housing, but it's also really about shifting the philosophical approach that we have for working with people, often people who have very complex needs. So one of the ways that you shift your philosophical approach to homelessness with housing first is it's about shifting a power dynamic. Even though we are all coming from really good places and serving people experiencing homelessness, there's still a power dynamic there, right? One of the young people that I worked with who did street outreach said, I literally have the power to decide if you get one juice box or two, right? So imagine that power dynamic even more amplified when the ability that you have is to deny someone housing or not, right? So it also shifts us away from paternalism in the context of young people. It's about rethinking it. The job is not parenting a young person or raising somebody. It's just accompanying people on the journey that they decide they want to be on. It also, and this is really important for the conversation that I want you guys to have about harm reduction, it shifts the burden for engagement to the provider. So when we think about the difficulties that are on us as for serving folks with complex needs, it can sometimes become, why won't they engage? I'm just doing everything I can and they just won't engage with me. And that's really frustrating. And that is absolutely true. However, when we're approaching something from housing first or harm reduction, let's shift the burden for engagement. What can I do differently to make it engaging? So as Mary talked about, let's listen to folks and let's hear what they have to say about what they need. Let's constantly put the burden back on ourselves for problem solving about what we need to do differently to make sure that the people that we are offering our services to find them relevant to the needs that they have. Okay. So that's my blurb about housing first. And just Mary and Nicole, just for sake of being able to maintain conversation with you guys, I am on the PowerPoint, so I can't see the chat in Zoom, but I do have my Slack open on my phone. So Slack me if I'm like frozen or something like that. Thanks, guys. Or if there's questions in the chat. As I talk about housing, harm reduction and questions come up or ideas come up, please put them in the chat. I want to make sure that we have a really robust conversation and discussion and really lift up the struggles that you guys have. This is hard work, and also problem solve around. So I don't want to miss anything. I probably won't stop during the slides, but I want to make sure that we capture all of it. Okay. So harm reduction. This is basically just approach to providing services that's focused on meeting people where they are. We say that all the time, but this is like really, really living it. And what we're trying to do here is just reduce the risks of behaviors that can cause harm. This is most commonly for the work that we do around substance use, but there are all kinds of other behaviors that all of us do, complex human beings, that have some risk involved with them. And so with harm reduction, we're just thinking about approaching this from how can we reduce the risk, right? And we measure success from this about just how much positive behavior change and even small changes are important to honor and affirm as successes. It also is an approach that honors someone's autonomy. They have control, they have choice. And for people experiencing homelessness, especially, so much of their autonomy, so much of their choice has been taken away for many folks over years and years, right? And this is a way to honor that autonomy. They get to define their path, but we're also not saying, oh, it's just anything goes and whatever, and I don't care what you do to yourself. We're still focusing on promoting health and safety, but not in a completely abstinence-based approach. So in Charleston, Mary had a great analogy where it's the service provider has the roadmap, but the person who is in housing now and in our programs is the one driving. So we're helping, right? But they're behind the steering wheel. So one thing that I think is really important for kind of grounding ourselves in harm reduction, but in just any aspect of this work that we do for people who are in crisis and who may have things that they want to change about their lives, like we all do, right? This is a very humanizing approach to homelessness as well. All of us have had experiences in our lives. Some of them, for those of us who are doing peer work, may actually be around substance use issues or serious mental illness or homelessness, all the way up to we all live a life where we're trying to maybe at this time of year change our eating habits or our exercise habits. For me, I am in a perpetual cycle of trying to not drink coffee, and I'm still drinking coffee. A very, very addictive substance, by the way, right? So we're keeping in mind when we're working with folks who are dealing with serious mental illness, substance use issues, any kind of changes that they decide they want to make, that a very human way to do change is kind of this model, right? So people may be in a pre-contemplation stage, which is where there's no intention of changing behavior because it doesn't seem like there's any reason to change the behavior. And we've all been in that place. You move into a contemplation where, okay, I think there's a problem here, but I'm not ready to say I'm going to do anything about it. Then we start thinking about, okay, we are going to do something about it. We're intent upon taking action to resolve this problem, to make this change, whatever we think it is. And then we actually make some changes. We change our behavior. Once we've changed our behavior, it's really important that we are sustaining that change. So this is building new habits, right? And that new behavior replaces the old behavior. However, relapse, that someone told me in Charleston, we don't call it relapse in the substance use program that she's a part of, but relapse has been usually the traditional word that folks use, but just call it going back to revisit, right? Revisiting old behaviors. And that's okay. That's part of the process. Again, that is how all of us go through life. That's how change works for human beings. I always really like this version of change. And it's thinking about what success is. Again, with harm reduction, we're celebrating all successes, small and large. And what success really is in all of our lives is a really messy process, right? Because humans are complex, life is complicated. And this is how we all go through it, including the folks that we're serving. So for harm reduction itself, there's really 5 key principles that this approach to dealing with homelessness and folks who are dealing with serious mental illness, substance use, any array of complex needs that our jobs are to support them through the changes that they want to make. It's about being pragmatic. Even though all of us come from a very kind of idealistic place in getting into this work, when we're actually doing the work, we really need to focus on being pragmatic, making sure that we're not being judgmental. So there may be some risks, some behaviors that have really high risks, but that is a part of being human. And there are often multiple complex factors that contribute to anyone's choices that they are making and their behaviors, and to how much harm they will experience as a result of those behaviors. Again, principle 2, it is the name of this approach, and it is about reducing harm, not necessarily reducing consumption or changing behaviors. Again, the most common way that we see this come up is in substance use. So we're not necessarily focusing on abstinence, but I do want to say it may be that someone we're working with actually wants to approach their substance use from an abstinence perspective, and that's important to honor that. But with harm reduction, that's not our goal for them. Our goal is just how can we reduce the harm of a particular behavior. Again, like I said earlier, and this is so related to Housing First, it is about someone's choice to direct his or her life, and they decide how to manage or mitigate the risks of the behaviors. It gives them their voice. Everyone that we're working with, just like all of us on this call today, deserves to be treated with dignity and respect. And this approach is a very respectful approach. And again, honors someone's autonomy. However, you're honoring someone's autonomy, and that also means expecting them to take responsibility for the natural consequences of their behavior. And this is where the real tension comes in. This is where you guys will experience the most need to kind of problem solve and the really hard part of the work that you do. So put a pin in that principle. That is the one that I hope that we can have a really robust discussion around, and that you guys as a community will commit to having constant conversations around how to problem solve around that tension. Okay, so again, you'll see here, you're pretty steeped in Housing First at this point. A lot of the characteristics of harm reduction are the same characteristics of Housing First. So we are removing barriers first and foremost. As you guys know, as I shared with you, I started this journey a long time ago in a really high barrier shelter for families. And I'm pleased to say now that program is low to no barrier. And it took a lot of hard work to get there. And a lot of times we hold on to the barriers because we think that things will fall apart if we don't let them go. But, you know, that program is just one of many, many examples of oftentimes the things that we fear from removing barriers don't actually come true. And we end up opening up our programs for the folks who need it most. And that is especially in the case of PSH, the important work that you guys do in the homelessness response system. Another characteristic is that we're not coercing folks. We are making sure that we are honoring individuals' choices and autonomy, and they get to decide how they are managing the risks associated with their behaviors, like we all do. It's being client driven. This is where when Mary was talking about, okay, someone's not engaging, let's listen to them about what they say they need and why they're not engaging, and let that drive the services that we offer. We're really focusing with harm reduction too, it's on immediate needs. And in the case of really potentially deadly substances like fentanyl, where the risk of overdose is so high. An immediate need can be literally saving someone's life, right? But we also want to set goals that are realistic and attainable for right now. We're celebrating folks' progress on those small goals. One of the examples that was given to me a long time ago was, if someone's goal is, I want to live in a 4-bedroom house with 5 bathrooms in XYZ really expensive neighborhood in my community. So for those of you who know Baltimore, that would be like Roland Park, right? That's a really great life goal. Right now, this is how much income we have. This is the options that are available to us. These are the things that we maybe need to work on over the next few years to get someone to a position where their income could be Roland Parkable, right? But we don't just completely dismiss that long-term goal. We bring it back to the short-term goal that is a step on the road to the long-term goal, right? So focusing on that and those small successes with the eye that eventually we're getting to that long-term goal. An important part of that is about resources and making folks really well educated about the resources that are available for that longer term goal and to help them meet those immediate needs. And it's really important to build relationships, as you guys all know, probably from your own lives. And the data is really, really important on this as well, is that often the thing that makes the most difference in someone's life is they can point to a caring and supportive person who supported them through a tough time. For people experiencing homelessness, especially those who are experiencing chronic homelessness and who may have been homeless for a really long time, those relationships have kind of fallen away. And it's really important to focus on building those back up as a part of maintaining stability in housing longer term. And you'll see here, and I hope this is also part of our discussion later, is we're sticking with clients that resist. So I know you guys have talked about trauma-informed care, but very often a natural trauma response is to not trust, right? And so sometimes what we're reading as resistance to our awesome services may be that someone just doesn't have enough trust in us yet to believe that we're going to continue to be there for them and follow through on the promises that we make. It's still also, as we keep saying, and again, this is the tension, about personal responsibility. There are natural consequences to folks' behavior, and those can be used to help motivate desire to different change in someone's life. And again, finally, harm reduction is about, this is related to building relationships. You're also developing partnerships for folks and making appropriate referrals for them, so that when at some point maybe the service intervention is kind of dialed back a little bit, this is more important in rapid rehousing than PSH, but you want to make sure that folks have all of those connections that they need, those interpersonal connections, but also the community connections that they need to really support and maintain and sustain change, including through what might be a relapse, and then whatever better word we find for relapse. So to wrap that up, again, bringing it back to housing first. Harm reduction is an integral part of the positive outcomes that you get through Housing First. And the same people who benefit from Housing First are the people who benefit from using a harm reduction approach. And that's especially important in PSH. It's for folks with high barriers to stability, folks with serious mental illness, with substance use, often co-occurring disorders, people who may be engaging in risky sex behavior or sex work. It works for young people. It works for older folks. It's really important for everyone that we serve that we understand this approach to change, and that we're able to implement it and make it most effective and supportive for the people that we serve. And I'm going to wrap up here. Mary, you know, and Nicole introducing you to. I've spent a lot of time over the course of my work now thinking about customer service. And so I'm just going to offer this to you guys as another way to kind of frame what can be sometimes feeling very social worky kind of academic concepts. And customer service is a way to also think about this work. So as you guys move forward in the work that you're doing, think about when you've had a really good customer service experience and kind of what were the qualities of that, when you've had a really bad customer service experience and what were the qualities of that. And you can frame the approach that you take to doing the work that you do in PSH kind of from that same lens. So this is what we have learned over many, many years of doing surveys with folks who are experiencing homelessness in all aspects of that, from unsheltered homelessness all the way up to PSH. When people don't engage, or when they are disconnected from services, this is what they say is going on for them. And so if we shift the burden onto us for thinking about how to promote engagement in our services, we really need to think about this feedback from the clients that we serve. So often when people don't engage with services, it's because they're not the things that the people think that they need, right? And that, again, think about good customer service in your own day-to-day experience. When you go to Starbucks, my Starbucks that I was at this morning, excellent customer service. And you know why? It's because they know me, they know my name. I feel seen, I feel heard. They always have a nice, friendly smile for me when I come in. And that's important. That makes me want to go back there. So even something as simple as a trip to Starbucks can be a good lesson for how to do some of this work better. Another reason that people might disengage from services or not be involved in the services that we are providing is that they feel like they don't have the best use of their limited resources internally. We also may not in our work feel like we have the best use of our limited resources. So it's really thinking about how do we maximize the resources that we have for the folks that we're serving and also for ourselves. People also, again, like we talked about, you guys have done a lot of work on trauma-informed care. People may fear negative consequences if they do engage with your program, and that's something to keep in mind. Thinking about how often people are engaging in services, when they need to engage in services, when we think they need to engage in services, does that align with what they think? And folks may just not have the capacity to engage. So these are all really important discussions for us to have. And now I want to stop my share and let's open it up to a discussion. First, I want to go back to this slide. Principle 5 here, individuals are expected to take responsibility for the natural consequences of their behavior. And let's have a discussion. Let me see if I can put my video back on. Okay. So again, if you guys want to, let's talk about this. I have some ideas and perspective, but I think you guys also really have the ability to problem solve around this. I think one of the ways that we do that is just having these problem solving conversations. You all are familiar with the concept of problem solving conversations because it's what happens in diversion. But this is, again, a way that all of us kind of function through life, right? Like, so here's an issue. Okay, let's think about all of the different possibilities about what might be going on with somebody, and then shifting the burden back to ourselves. What's a way that we can respond to this that isn't someone becomes homeless again?
So Mindy, just to start, along the way in our conversations, we've had people bring up the fact that while people are in permanent supportive housing, that they are engaging in very problematic behaviors, that the natural consequence would typically be eviction from the program, but there is a very real incentive to do everything we can to keep someone in their housing and to help them move forward. What is the best way to address that situation?
So I think we talked about this earlier, and let's say we as a community, we as a program have made a commitment to whatever happens, the thing that we will not do is exit someone back into homelessness. And anything that I say to you guys, I learned from providers and from my own experience doing frontline work. So none of this is like, oh, Mindy came up with this thing. This was a really, really powerful story from a program in New York City that had traditionally been a high barrier transitional housing program. And they were shifting to, like, we want to become a housing first program. So it wasn't transitional housing anymore. But anyway, they're making the philosophical shift. And so there was a long period of like the contemplation, right? Like even when you're making change in a program, you're in pre-contemplation, you're in contemplation, you're thinking about what needs to happen. So part of that contemplation was really thinking about, if we as an organization want to make a commitment to this philosophy, what does that mean? Let's drill it down. And they decided their boundary was, we 100% will not exit someone into homelessness. That doesn't mean it was just anarchy running amok in their program and people were doing whatever the hell they wanted, right? Like it wasn't like that. There were boundaries in the program. There were expectations in the program. But what they said, to put the burden back on them, because it's a program, right? Like it's not your personal home with your child where you do get to have different kind of boundaries and consequences. This is our job. And so what they committed to is, we will not do this thing. What having that boundary did was, then when a situation comes up that is problematic, like, okay, this person there's a lot of harm to them happening here, possibly harm to other people living in the building, all of those things that you guys can talk about. Okay, we got to deal with this problem. Let's figure out how to deal with it. But the option that won't be one that we use to deal with it is just exiting somebody back into homelessness. So you can see how making that commitment opened them up and kind of put the burden on them to figure out other ways to have consequences for that behavior, but the consequence wouldn't be homelessness. Now, problem solving, right? So let's problem solve around this. For the example of this program, it was, we want it to be a last resort, but someone may be doing real harm to someone else, and that may require connecting with law enforcement, right? Like, so they had this range of possibilities for stuff. And it also included ongoing communication and connection, and thinking about things like, maybe it's this caseworker is just not the most effective interpersonal connection with this client, right? Opened up a lot of different things. That is my response to that. That may not be satisfactory. I appreciate how hard this work is. And sometimes you just want to have a really easy, like, well, this person is just not in the program anymore. And it may be that person is not in your program anymore, but then there's an additional burden on you to figure out, okay, not in this program. What do I help connect this person to in the community? Mary, I'm thinking about the conversation that we had about mental health institutions and the work that you did for Olmsted about there are different options than group homes, right? That are least restrictive options. Least restrictive option, coming up with that kind of stuff is the same kind of problem solving about really, really serious and complex issues. So I'll put it back on you guys. Let's problem solve around it. What are some options for those really, really difficult situations that don't include exiting somebody back into homelessness? And I will also offer to you too, as part of this kind of problem solving conversation, get it all out there. All the different possibilities, even if they're unrealistic, just throw them all out there, right? Like throwing things at the wall to see what sticks. Let's get them all out there and then start sorting through them. And there may be some things that's like, oh, this is ridiculous and will never happen. There may be some things that somebody will say, I never thought about that. There may be one where you say, I actually know somebody, right? And we're networking, right? On an interpersonal level, we're networking. And I know somebody who, for example, my landlord has a child, an adult child who has special needs. And nobody knows this in Baltimore. Nobody knows this in the COC, but he, on an interpersonal level, has one unit in his little tiny building that he rents to folks who are on SSI with special needs. That's just something that you learn on an interpersonal basis. So when you guys make space for yourselves to kind of problem solve around issues like that, little things like that can come up. Christina says, what if they sign agreement stating they agree to abide by the rules, noting that if they break one, they could be removed from the program or housing? They could be removed from the program or housing, but then what happens after?
So I'm wondering if it's scattered site housing, even if it's scattered site, rapid rehousing, or permanent supportive housing, and the landlord has just had enough, and that things are happening, and potentially the person has to leave that particular housing. I would presume that if a program has a commitment that the person will not be removed from the program, there will be an effort to find new housing and maybe use that loss of the original housing as a teaching moment to try to move forward and reduce harm in the next space.
Just for folks who may not be aware, if you want to add a question or comment and you'd like to do it anonymously, there's another poll that's open, and we'll close that in just a few moments.
Hi, I'm Kendra with Memorial Behavioral Health. I'm a peer recovery specialist, and I work with our unsheltered population. So all of the people that we see daily are either in a shelter or outside. And what I see is some people are so sick, and it could be a developmental delay that hasn't been addressed, or it could be the severe mental illness. And they get to a certain point where they just revolve between inpatient, ER, jail. And it's because of their diagnosis. And so I've said it before, but I'm like, if we could just take a little bit of their rights away to get them safe, in a perfect world, but because they have that choice is where we struggle with some of our people.
Yeah. Kendra, thank you for bringing that up. That is the thing, Mary and Nicole, I think our field has kind of, for a long time, avoided talking about that because it was like, well, no, we don't want to institutionalize anybody. So historically, you guys know that previously the way that we approached as a society folks with serious mental illness was an institution, right? So the insane asylum, the mental health institution, and deinstitutionalization happened in the 70s, which was a good thing because those were appalling. However, deinstitutionalization was supposed to have community group homes, right? So people would be able to live in the community with the services and supports that they need. That never got funded adequately enough, which actually was one of the contributors to quote unquote modern homelessness. And it's what PSH was originally designed to address, to kind of fill that space. I think we should have, as a community, conversations about that. Mary, I think your experience doing Olmsted in Mississippi and Tennessee is really informative for this conversation. So you guys have, as a resource, a really good resource in Mary from thinking those things through. And I used to would have knee jerk said, well, that's not housing first. But I think we do have to have a conversation. Are there some folks who are in a place where they're not able to make decisions, have choices, to consider their own physical well-being? And who are those folks? How do we distinguish who those folks are? How do we have something in place for those folks that I think is a tiny bit of the folks, right? I don't want to say that that's everybody, because part of what went wrong was everybody got painted with that brush, right? And there were racial disparities involved in that too, right? Like there's just a lot of reasons, but we kind of, as a society, swing from one side to another side, and we lose a lot of the complexity of the middle in trying to address the extremes. But Kendra, having done direct work, and for folks who are in recovery, especially, and peer support folks, like I think we have to figure out what the response is. Mary, would love to hear your perspective on that from the work that you did with Olmsted.
So Kendra, I'm curious, is the choice that you're talking about their choice to participate in mental health services or their choices around housing?
It's really both. They don't know that they're sick because they're so sick. And then they get into that habit, that cycle, and they don't think that they need to get out of it.
So I'm wondering, are you able to do assessments out in the field as you're talking to people who are unsheltered, who are in that cycle, as far as mental health assessments?
Yeah, we have a mobile crisis response team and everything. The problem that we're running into is they may involuntarily send them to the hospital, and the hospital has seen them so many times. We're getting them discharged within hours. And some of these folks have been sick for years and they just keep cycling through. And so there are people that we know can't take care of themselves, but even our mobile crisis team can't get them anywhere.
That is a real challenge. And I think that we can potentially create a small group discussion. I know this is our last formal training, but maybe a small group discussion to kind of tackle some of that, because I think in other communities, it has required is a partnership and a commitment from the Department of Mental Health and the community mental health centers partnering with outreach teams, so that the involvement of the mental health team isn't always the involuntary commitment, but is some form of addressing the situation and some level of not quite treatment, but getting that direction to help someone choose the next step that would make sense for them. I would also offer that if people are able to move into housing, particularly permanent supportive housing, even if they haven't agreed to treatment yet, they oftentimes will stabilize a bit just getting out of survival mode, just getting into that place of, I have a locked door. I have a refrigerator. I can eat when I want to, and I don't have to go search for food. And getting out of survival mode can help someone make a different choice in their treatment. So I think that might be another small group discussion, if we can kind of work that together after this. But I think those kinds of commitments where you doing outreach have the support of the COC and the leadership and Department of Mental Health to be able to help that person through motivational interviewing and other strategies make some better choices. So, Mindy, I know this seems unsatisfying because we didn't come to the answers to everything, but at least it's hopefully a step forward. I am a big proponent of partnerships in this work.
Yeah.
That no one agency, no one group, no one set of really great outreach workers can solve this whole issue. But recognizing that through partnerships, we can create the kinds of services that people need to make better choices and healthier choices in their lives. And Kendra, I know I didn't really answer your question, but I hope it was helpful.
It was, thank you.
Well, thank you so much. I think we're going to focus now just a little bit on coordinated entry. Just because this is a piece of the training that we have to get through. Although I just really love the discussions that Mindy leads. So I hope you all enjoyed that as well. Thank you very much for your great questions. So Nicole, if we could go to the next slide. As you all are aware, the coordinated entry was designed by your community to streamline entry into the housing and services that are funded by HUD in your community, which would be the PSH, Permanent Supportive Housing, and Rapid Rehousing. The goal is to allocate effectively as effectively as possible so that the people most in need actually get access to these resources. The thing is, at the very beginning of time, when these programs, permanent supportive housing and rapid rehousing came to be, the people who were the loudest were often the people who were referred to the programs. The people who said, I really need to be in that housing. I really need to be in that housing. And someone says, okay, you officially qualify. As opposed to coordinated entry, where we really are trying to determine the people most in need. And maybe it is that person who's suffering on the streets with an untreated mental illness. And we know that housing will help to stabilize so that person can then make a decision to move forward. The coordinated entry process takes all of those things into account: the length of time homeless, the disability the person may have, the fact that if someone doesn't get housing, they are likely to die on the street. That is what coordinated entry is looking at. And you may say, well, gosh, this person meets all the requirements for permanent supportive housing, and coordinated entry makes a referral of someone else. It means that someone else has a higher need. And it doesn't always seem fair because resources are so limited, but coordinated entry is designed to identify the people most in need and make those referrals to the programs that are funded through the HUD Continuum of Care, which include permanent supportive housing and much of the rapid rehousing in the community. So the coordinated entry priorities for the Heartland Continuum of Care would be chronically homeless individuals and families would be first and foremost. That means they meet the definitions that we talked about. Chronically homeless people with the most severe needs. So you can see through these different coordinated entry priorities, it's going to be people with the longest histories of homelessness and the most severe service needs. And that brings me back to the comment I made before. A case manager in permanent supportive housing is not a psychiatrist, is not a nurse practitioner, is not a doctor. They have really important skills in helping people maintain their housing, but are not expected to provide all of the treatment that someone might need for their mental illness or for their substance abuse disorder or for their primary health needs. That's where these partnerships and connections to the community are absolutely critical so that people have what they need in housing. They get to choose those services, but using motivational interviewing and other techniques, once someone is safely in housing, people are able to help move that person forward in making different decisions. Housing first and permanent supportive housing. Mindy did a great job talking about housing first. Really what Housing First means, it's not housing only. It's not housing instead of treatment. It's not housing instead of rehab. It's housing so the person can just be, have a locked door. They can start thinking about what is next. In Housing First, we've talked a lot about it, but just looking at the fact that homelessness is a housing problem. There are a lot of people who have untreated mental illnesses or have a substance abuse disorder that's pretty significant, or have a wide range of other issues who have never been homeless. The fact is that someone is experiencing homelessness because they don't have either the family resources, because maybe they've burnt those bridges, they don't have the income. There are other reasons that point to the fact that their homelessness is primarily a housing problem. It means there's other issues potentially, but housing is the real problem. Once someone's housed, they're not homeless anymore. They may still be struggling with the other issues, but they're not homeless anymore. The Housing First principle believes that housing is a basic human right, that people can and should be stabilized in permanent housing. Underlying issues can be treated and best addressed, and people can make those important choices once they're safe in housing. And independent living actually empowers people to meet their goals and address their challenges. Mindy mentioned that I have a long history in helping communities provide housing that serves people living with mental illness in the least restrictive environment. It is amazing when people are empowered to choose treatment, empowered to choose their housing, and it meets their needs with appropriate supports, appropriate case management, appropriate supports in the home. Oftentimes that might be a PAC team in the mental health side. People really can move forward in a way that nobody imagined, particularly that person if they have a long history of untreated mental illness. But that goes for other things, other substance abuse disorders and others. Once they're in housing, they can make the choices that are healthier and help them to be empowered to move forward in a better way. And so we'll kind of move through this quickly because we don't have a lot of time left. But in Housing First, there are no requirements regarding sobriety or participation in services. That comes once someone is in housing. If they're choosing a sober living environment, then we should have those available. But generally, abstinence is not required. And we should be looking at people's choices. There's no requirement regarding what their financial situation is. They can have zero income. They may have a criminal history. The program should be accepting coordinated entry referrals. And if a particular program doesn't meet their needs, then coordinated entry can refer them to another program. But keep in mind that that these referrals from coordinated entry should be a good match for the program. We should not be saying no to people because of their history or their credit or things like that. There is no requirement for participation in services, but the burden is on us. We have to be ready to provide the services as soon as the person says they're ready. If we've been working with someone and all of a sudden they said, you know what, I'm ready to go to rehab. I want to go. I've decided. And if you say, oh, we might be able to get you in 6 months, the time has passed. We have to be ready to say, okay, I can get you in now. We have to take advantage of those moments when people decide. We also can't use alcohol or drugs as your basis for eviction. The commitment should be there that people will not be exited from the program. We will be employing harm reduction strategies to help people stay in housing. Again, prioritizing vulnerability, providing the things that the program requires, like the rent payments, case management, and special accommodations for people with disabilities. And I'm wondering in the last 5 minutes or so, if we have any questions. We will be sending out both sets of slides, and we're available by email if someone has specific questions they might want to talk about. And we'll be getting with the Heartland House COC about maybe that partnership discussion that we talked about. Anything else that anyone has questions about or concerns as we wrap up? Hey, Nicole?
Thank you all for joining. And that concludes today's training. Thank you again to Mary and Mindy. And like Mary said, all of this information will be provided by Heartland House. So they will have the recordings, they'll have the slides, and they will share that with you and make it available on their end. So thank you again.
Thank you, everybody.